Good morning, everybody. Thank you for joining us for another session of the AOMSI JC series. We have had to reschedule this session owing to our nationwide trauma campaign from the head office that was conducted on 26th of August, that is Saturday last. I hope many of you were able to participate in it and do a good deed on part of the association in educating our youngsters on the importance of managing road safety mechanisms. So today we are having our session from the North Zone this time as a second session for the year 2023. And it is from the Institute of Dr. Hashmi. That is, I just have to read the exact sentence. That is the Ziauddin Ahmed Dental College and Hospital, Aligarh, from Aligarh University. And our presenter for today is going to be Dr. Akash Ganguly, and the head of the department is Dr. Hashmi. And our moderator for today is none other than Dr. Abhay Kamath. And Dr. Abhay has been chosen as moderator for very obvious reasons, because the article actually is going to talk about more autogenous possibility for a temporomandibular joint reconstruction, and he is one person who does quite a lot of joint replacements. So without further ado, Dr. Abhay, I hand over the session to you to conduct this. Thank you.
Thank you, Yash. Good morning to everyone across India. My regards to the head of the department, Dr. Hashmi, the presenter, Dr. Akash, all my fellow colleagues across India who have joined us on the web live. Today's topic for discussion is the medial femoral condylar reconstruction for temporomandibular joint afflictions. As we all know, temporomandibular joint is an orphan joint, and I think as of now, we as maxillofacial surgeons need to adopt this joint. We have thrown all our elusive hammers to this nail with the help of arthrocentesis, arthroscopy, balancing acts giving splints. But however, all this has been of little relevance when it comes to a joint which has totally degenerated because of obvious reasons when you speak about it in terms of arthritis, anterior disc displacements, and so on and so forth. The list is unending. So I think it's a holy grail to the maxillofacial surgeon, if you ask me, as a joint replacement, which is in vogue today. You see everybody across India doing TJRs, joint replacements. I think this topic of choice, which is made by Dr. Sarwar and his postgraduate, makes sense in today's times to understand what other treatment modalities we are looking for. Without wasting much time, I hand over the entire presentation to Akash. Welcome, Akash. Kindly go ahead.
Thank you, sir. Shall I share my screen, sir?
Please do, Akash.
With your permission, shall I begin, sir?
Please do.
Thanks. Good morning, one and all present here. Myself, Dr. Akash Ganguly, from Dr. Ziauddin Ahmed Dental College and Hospital of Aligarh Muslim University. Today, I'm going to give the Journal Club presentation under the able guidance of my professor, Dr. Hashmi. The topic is temporomandibular joint reconstruction with medial femoral condyle osteocartilaginous flap, a case series. The reason behind choosing this article is the fact that the authors have used medial femoral condyle as a means of reconstructing this TMJ reconstruction, which is indeed a very innovative method. The authors are L. Shia et al. Their affiliations are from the Department of Oral and Maxillofacial Surgery from Peking University School and Hospital, National Clinical Research Center for Oral Diseases, Beijing National Engineering Laboratory, and Beijing Key Laboratory of Digital Stomatology, all from China. This article was published in the International Journal of Oral and Maxillofacial Surgery. TMJ has an important role in mastication, speech, as well as facial aesthetics. So accurate reconstruction for the large-scale defects of TMJ is very essential. In today's world, the reconstruction of TMJ can be a very challenging defect, can be a very challenging procedure. So this defect is filled with the utilization of MFC flap by the authors here. Traditional surgical methods include vascularized and non-vascularized autogenous reconstruction, as well as alloplastic means. If we take the autogenous non-vascularized grafts, there may be severe resorption. The vascularized grafts may have donor site morbidities. The alloplastic prosthesis, on the other hand, may not be available. And even if it is available, it may not be affordable in many countries. So it is important to identify alternative methods of reconstruction of TMJ. I feel this MFC flap is well suited for complex reconstruction, and the authors have said that they constitute of the cancellous bone, the cortical bone, periosteum, tendon, skin, all required for complex reconstructions. There is the donor site morbidity is acceptable with good level of postoperative function. These flap with the articular cartilage has not been previously utilized for reconstruction of large-scale TMJ defects, and here the authors have utilized this technique for treating 4 patients at their hospital. Their aim was to describe the technique of harvest as well as present the preliminary results. Coming to the materials and methods, in between 2019 and 2020, 4 patients, that is 3 females and 1 male, was operated with the age range of 40 to 59 years. The primary diagnosis were condylar osteochondroma, condylar osteoma, and 2 patients of type 4 TMJ ankylosis. They were followed up for a period of 6 to 11 months, and written informed consent was taken from all of them. If we see this table here, we can find that 3 of the patients had the side affected at the left side and 1 had on the right side. The largest size of the defect was 40.7 into 22.5 mm, and the size of the flap that was harvested, the maximum size was 51.5 into 31.9. The maximum mouth opening was from a range of 24 to 36 mm, and self-evaluation of the appearance, we get 9 out of 10 in 2 of the patients. Whereas the LEFC score, that is the lower extremity functional questionnaire, having a scale of 0 to 80, 2 of the patients scored a perfect 80 out of 80, and these patients were followed up for about 6 to 11 months in this case series. Coming to the surgical procedure, preauricular incision was given to expose the TMJ for undertaking the condylectomy or osteoarthrectomy from the top of the glenoid fossa till the residual ramus. Resection of coronoid process was undertaken to ensure maximum, if it was necessary, to ensure maximum mouth opening greater than 40 mm. Also, the transverse branch of the descending genicular artery was preserved because it has a course which goes anteriorly from towards the medial condyle and supplies almost the maximum portion of the convex cartilaginous portion. So when it is preserved, it can be utilized as a free vascularized flap. Now, after condylectomy, there were 2 teams proceeding with the process. Well, the first team had the main surgical team with the authors in them. They were responsible for the microvascular anastomosis. They had prepared the neck on the recipient side, and they were preparing the recipient vessels for microvascular anastomosis. The second team harvested the MFC flap along with the pedicle consisting of the descending genicular artery. This image, we can see a pre-made surgical guide which confirms the shape of the flap before the osteotomies in the donor site. And in the recipient site, it can be used to adjust the position of the flap to the glenoid fossa. Then this flap is fixed to the mandible with the utilization of 2 mini plates. Then for interpositional arthroplasty purpose, the temporal muscle myofascial flap was used to obliterate the soft tissue defect and separate the bony flap from the skull base. And microvascular anastomosis was completed using an operating microscope and the wound closed after the suction drain placement. All the surgeries were performed by the same team and having senior surgeons in the field of reconstructive surgery. For virtual surgical planning, all patients were made to undergo spiral CT with maxillofacial and knee joint regions. ProPlan CMS software was used for the 3D model, and resection margins were determined using the clinical and 3D radiographic findings. Then condylectomy was simulated using the software. Flap was planned based on the defect shape as well as size, and these 3D specific templates were used to shape the bony flap based on the mirror images using the CAD/CAM technique. I will show this to simplify the things said by the author. This is a picture from the article directly. This is showing the 3D radiographic image of the femur. The MFC flap has been simulated, and this is then being taken to the defect size, and this is designed as per the unaffected condyle, the native condyle of the unaffected side using the mirror image. And this is the split. This is the surgical template that is used at both the donor and recipient side. This is the donor side as well as the recipient side. At the donor side, we can find the descending genicular artery with the two branches, that is the transverse, which is supplying the majority of the cartilaginous portion, and the horizontal and the longitudinal branch. This is then transferred to the recipient side to anastomose with the facial artery. This is the side of harvest of MFC flap, and this is the particular dimension of the flap after the splint has been, after the surgical template has been utilized. This is the recipient side where the MFC flap has been placed, and this is then fixed to the mandible with the use of 2 mini plates after the microvascular anastomosis here was achieved. Coming to the post-operative management, mouth opening exercises were started from 1 week after the surgery and continued for 3 months regularly. Facial symmetry was self-evaluated and scored by the patient at a scale of 0 to 10. A score of 0 to 3 was considered poor, 4 to 7 was considered fair, and 8 to 10 for good. The lower extremity functional status was assessed using post-operative knee radiographs, as well as this LEFC score, that is the lower extremity functional scale. It is basically determining the degree of difficulty in performing different physical activities. The score can be 0 to 80, 0 suggesting maximal disability and 80 suggesting no disability. Coming to the results, the post-operative hospital stay, it was for 8 to 10 days. The maximum mouth opening at the follow-up was 24 to 36 mm, and all patients had slight deviation of the mandible to the affected side. Facial symmetry was self-evaluated with 3 patients considering it good and 1 patient fair. Again, post-operative CT and 3D images were utilized that showed excellent anatomic restoration with the bony flaps according to the authors. The flap success rate was found to be 100% with achieving patency and osseous union. All the patients, however, experienced pain and numbness of the skin at the anteromedial aspect of the knee, where the symptoms had resolved without treatment in 3 months. And it suggested that there was no flap-related complications like any flap necrosis or hemorrhage or vascular thrombosis, with the normal load-bearing occlusion within 6 to 11 months after the surgery. Coming to the discussion, as we have discussed earlier, the different means of reconstruction. We have the alloplastic, which especially the custom-made ones are safe and predictable, though they are not available and may not be affordable as well. As for the non-vascularized grafts, this may show severe resorption, where a large defect has to be reconstructed. Huang et al. Found a high frequency of bone resorption when the free coronoid process and the costochondral graft in adult patients were undergoing condylar reconstruction. Although this is considered suitable for children with intrinsic, due to the fact that it has intrinsic potential for growth, it has certain disadvantages like the unpredictability of growth pattern, resorption, failure to grow, and overgrowth. The heights of condyles are may be reconstructed by transport distraction osteogenesis as well. And according to the original authors, that is Chen et al., they did a study in 2011 where they found the resorption rate using this technique to be 59.4%. Now, again, Chen et al. Tackled the shortage of blood supply by using a composite flap. That is, they modified the sternoclavicular joint by using the superior half of this joint pedicled with the clavicular head of the sternocleidomastoid muscle and utilizing the superior thyroid artery, its sternocleidomastoid branch. But this technique was associated with high risk of donor side morbidity, and the clavicle had to be fixed with thick titanium plates to avoid fracture. These problems can be overcome with the use of vascularized bone flaps, since they have lower bone resorption rates and superior bone quality. The workhorse flap comes into picture, that is the 3 fibula flap. It is the first choice whenever bony lengthening is required in reconstruction of subtotal or total mandibulectomy. But this flap has been found to be more reliable for the reconstruction of total mandibular defects and defects that cross the midline rather than the large-scale TMJ defects, because it is difficult to confirm whether it has precisely inserted into the glenoid fossa with the fossa exposure when the fossa exposure is inadequate. There is no real cartilage-covered condyle also when the conventional fibula flaps are taken. The problems mentioned by the authors here with the fibula flap are peroneal nerve damage as well as donor side morbidities such as ankle instability, stiffness, motor weakness or clawing of the great toe, and tendon exposure secondary to skin graft loss. Before coming to the medial femoral condyle flap, let us see a representative case given by the author. This patient came to the OPD with a chief complaint of discomfort and swelling with respect to the left preauricular area. In this radiograph, the CT, we can find there is destruction of the condyle by the tumor, by the benign tumor, and the condylectomy was done. After the surgery, after 9 months, we find that it has the MFC flap is present, and there is very minimal resorption, and the mouth opening is also adequate. So this flap has many advantages, and before this reconstruction of TMJ defects, it was utilized by many authors at various head and neck sites like orbit, maxilla, mandible, and even for airway reconstruction. The importance, as we know, of subchondral blood supply for the nutrition of chondrocytes and articulating cartilage is well known. Some authors who describe this MFC flap, like Lee et al., who gave the MFC bone flap for the treatment of malunion after subcondylar fracture. Zeman et al. Concluded that there was minimal zonocyte morbidity after harvesting this flap, with no patients having knee joint instability or limitation of range of motion. Higgins et al. And Benley et al. They considered that the vascularized osteochondral flaps had superior cartilage organization as well as bone resorption, less bone resorption rate as compared to the non-vascularized ones. In 2008, the first vascularized MFC flap was given for scaphoid reconstruction. Then subsequent studies came up for carpal reconstruction, advanced Kienbock disease, lunate reconstruction. Cadaver studies have found that DGA, that is the descending genicular artery, has good and reliable periosteal perfusion and can be used for non-union defects that have been conventionally treated with the fibula flaps. So the surgical repair of TMJ defects is difficult because of the complex tissue reconstruction having the hard and soft tissue defects. So all patients who underwent large resection for tumor or the extensive bony ankylosis, here free bone grafts were not enough to repair such defects. Author's technique of reconstruction had the following advantage when he used the MFC flap. He suggested that there was sufficient cortical and cancellous bone to pack the defect. The cartilage of the MFC flap resembled the TMJ cartilage anatomically, as well as the preservation of this DGA, that is the descending genicular artery, prevents postoperative bone resorption as well as provides successful functional rehabilitation. In 2018, Enzinger et al. Used lateral femoral condyle flap harvested from almost the same region as the flap authors used. But the authors have given the following advantages with their technique of utilizing the medial femoral condyle. They said that there was the combined preauricular and submandibular approaches gave better exposure, more extended resection, and more choices for internal fixation. Another thing was that they chose the facial artery as the recipient vessel for microvascular anastomosis, as there was no need to fold the descending genicular artery for anastomosis with the superficial temporal artery. And the aim was to obtain a triangular shaped flap with narrow side at the condyle with a wider part at the mandibular body. To the author's knowledge, this is the first report of the use of MFC flap with articular cartilage for TMJ reconstruction. The preliminary results suggest satisfactory restoration of the height with facial symmetry, and there was good recovery of function at the mastication, articulation, and speech level. However, it has certain limitations as pointed out by the author himself. The transplanted bone flap will inevitably thicken at the affected site, as it was seen in one patient. The author should have investigated the histological aspect, but this was not possible due to ethical constraints. And large prospective studies with longer follow-up periods are needed to determine the long-term outcomes as well as the risk of late lower extremity functional problems. After this article, I would like to do a critical analysis of this article. First of all, I would like to give full credit to the authors for bringing up this innovative and novel method of reconstruction of TMJ defects. It has various advantages as given previously by the authors, like sufficient cortical and cancellous bone resembling the TMJ cartilage anatomically, reducing post-op bone resorption, having no flap-related complications as given by the authors with no flap necrosis, thrombosis, hemorrhage, and negligible donor site morbidity. However, some points I would like to point out is that the authors had a small sample size and it was limited to 4 patients. So I think a larger scale study with much greater cohort is needed for broader applicability and potential complications, knowing the potential complications. Also, the follow-up period was short from period of 6 to 11 months. So potential complications like bone resorption and changes in the patient satisfaction, I don't think it can be can be studied in that duration, it might require a longer follow-up period. And due to ethical constraints, the histological transformation could not be done. So it limited our understanding of the structural and functional changes of the flap. Again, the generalizability, well, the success depends on the expertise and the patient selection criteria. And this was specific to a patient population, that is the Chinese population, as well as the clinical scenarios. The grafting was done on the adult patients, and patients of growing age were not a part of this case series. So it is interesting to know whether the young patients can also be used, can be a part of this case series. There is no mention of the TMJ movements like lateral excursive or protrusive movements. And it would have been better if a study comes up where comparative analysis between the available vascularized grafts are done extensively. Though here we get one example by Chen et al., where he has modified the sternoclavicular joint. And also the operating time, since every new technique takes time to learn. I think the operating time will be initially more, and when the doctor or the surgeon masters it, there will be less time. And also this requires the expertise in microvascular surgery, which has itself a long learning curve. Coming to the title and aim, I think the purpose of the study has been best explained by this. Material and methods, as previously discussed, there's a small sample size and short follow-up period. The results were considered to be excellent, with 100% success rate having no flap necrosis or vascular thrombosis or hemorrhage. But I feel the short cohort and the small cohort and the short follow-up period should be made up for in a next study, and like the authors can work upon with a greater population and give the potential complications that may be associated for its broader applicability. In the discussion part, I think all the relevant literature with 28 references have been covered till the time the article was published. Coming to the authors are oral and maxillofacial surgeons. So it is interesting to know whether it was a maxillofacial surgeon himself who harvested this flap, or there was some collaboration with plastic or the orthopedic team. Coming to the study design, it is a case series. It is an appropriate study design to describe new treatments. So this case series design is not considered the strongest source of evidence due to the absence of a control group. It provides descriptive information and knowledge and generating hypothesis. Coming to the evidence that would make the author's case either stronger or weaker. I feel that I think in not my thinking, like in previous case studies, and there have been reports, like there have not been any report that has described any functional knee joint impairment after this flap procedure, because this harvesting site is close to the knee joint, as well as have the presence of medial collateral ligament. So there might be any functional knee joint impairment, though no case reports till now have been reported. Coming to the clinical context, I feel that this flap has the potential to change the clinical practice, as various case reports have stated this flap as an ideal graft, but more evidence is required to make this flap a game changer in the reconstruction domain. Finally, I would like to conclude by saying that the authors have done an excellent job by enumerating about this innovative approach of TMJ reconstruction in countries, especially in developing countries like India. It is important where there are a lot of cases of TMJ ankylosis with dire need of solutions. So this flap can be a game changer in the future, but it requires the microvascular surgery expertise with maxillofacial surgeons from the dental domain. I think they need further training to master this flap, master microvascular surgery, and then again to learn any new technique. And to implement this technique, we need more evidence. I hope the present author, as well as authors from other centers or surgeons from other centers, work more on this and provide more studies with larger sample size and longer follow-up period to come up with better results and better outcomes. Thank you.
Thank you, Akash. Indeed, it's been a fantastic presentation. I must really congratulate you. You have done an in-depth analysis of the article. Congratulations to you and Server. It's been very nice to listen to the merits of the article, the shortcomings, the strength and the limitations.